what I want to do in the formal part of the remarks is to really talk about the argument around healthcare at the moment. And I want to start with the famous legend of Bevan and the upholstered chair in the Department of Health. And this famous lines Bevan is supposed to have said, "This won't do," he's supposed to have said. "It drains all the blood from the head and explains a lot about my predecessors." And he changed the chair. And I think this is exactly what happens when politicians start to discuss the National Health Service. They become infected with this sort of glutinous sentimentality. And the NHS is like the monarchy of public services. It's sort of solvent into which all critical thinking dissolves. I want to apply some critical thinking to it. And in particular, I want to talk about integration. I'm very struck by Rudolf Klein's brilliant description of the NHS as something like a restaurant where one person orders the food, another eats it, and then someone else turns up to pay the bill. And the demand for integration is something you see written through the history of the NHS from its very beginning. And I want to argue that integration from the centre is bound to fail. It's a hopeless endeavour. And in particular, I then want to talk about patients, because it strikes me that every problem that you encounter leads back to the centrality of the role of patients. Just take stock of where the NHS is today. After what I regarded as a foolish and rather pointless structural reform, arranging 151 PCTs into 279 CCGs, or however many it will turn out to be, at the same time as a £20 billion squeeze out of the system, and mid-staffs and the morale calamity and the shift back towards a fairly centralised risk aversion, and cost pressures are building and the waiting lists are growing and A&E is struggling to cope. And this against the backdrop of some chronic and very familiar problems, the ageing population, the rising burden of chronic disease. By 2030, a fifth of Britain's population will be elderly. Public expectations, of course, are growing all the time. A generation is growing old who've become accustomed to very high levels of service. A very demanding generation is about to enter the NHS in its twilight years. The nature of disease has changed. The last century was all about beating infectious disease, and this one's about chronic disease. 70% of the NHS budget going on the 15 million people who have a chronic disease. For every £10 spent in the NHS, £7 goes on this part of the care. At the same time, we're spending across the developed world about 5% of health expenditure on public health. Clearly, the resources and the coming problems are not matching. And for a system established under the rubric of command and control, in which power really resides with experts and patients are sort of expected to be supplicants, this is going to require a revolution. The 2010 Commonwealth Fund report compared 7 health systems in wealthy countries. The NHS came top for effective care and for efficiency. On putting the patient in control, it came bottom. That strikes me as the predicament we're in. Now, there's some well-trodden paths of reform that need political will rather than any more intellectual inquiry. I don't get the sense at the moment that anything particularly interesting intellectually is happening in the realm of politics, but there's an awful lot of interesting work going on outside the realm of politics in the health arena. I think it's very well attested that we need to shift the burden from primary and community care out of hospitals. However, this is one awful task for any politician to endorse. There's a great deal of consensus, as Nigel was saying, about the reconfiguration and closing hospitals, and not for reasons of failure most of the time, but for reasons of success. So routine problems such as hip replacements don't need to be done in the district hospital. Heart attack victims, coronaries and strokes, people are avoiding death or disability because they're treated in small specialist units. So the configuration of required services, of course, has changed. However, the tenacious hold of the local sentimentality around the institutions is very difficult for politicians to gainsay. It is a brave politician who will do that, and not many are brave, particularly in the year before an election. I think we need to, and again, there's a great deal of consensus about this, to shift the focus from treatment to prevention. And again, this is very, very difficult to do, politically speaking, because what that means, in effect, is usually running two budgets at once. To transfer funds from treating existing conditions to preventing conditions that have not yet materialized requires you to find some magic money. And it's not just during a period of austerity that that's a very difficult proposition for any government. So although politicians will constantly talk about shifting from treatment to prevention, and all of the time I've watched politics, I've heard this conversation going on. In fact, if you look at what happens, it very, very rarely happens. It's not through bad intention or even necessarily through maladministration. It's usually through the sheer difficulty of doing it. And there's never, in fact, an imperative to do so. There's never, in fact, it's never quite bad enough. And of course, the politician always, once you get into power, has an incentive not to describe the NHS as in crisis, but of course as improving. So therefore, it's very difficult to warrant saying we need a major change, because actually, whilst we're administering it, it's all going very well, thank you very much. At the moment, a lot of this is coming together in the debate about integration, which is what I want to concentrate on now. And my proposition is that integration really can only take place around people rather than around systems. The National Health Service is the most systematically minded institution you've ever encountered in your life. Everybody takes a place within its system. And I very rarely go to a health conference and find patients are in any way represented or even talked about most of the time. It is usually descends into a discussion about how this part of the system connects with this part of the system and with this one. And at the moment, how do we bring them together? I mean, we all know, of course, that people with multiple chronic conditions need integrated care. But there's a lot of confusion about what that actually means. I like to play a game, which is a very journalistic game, where I make people talk about integration without using the word integration. But what it makes them do is actually describe what they're talking about, and you immediately find that people are talking about different things. I used to do this in the city a lot. So there was this term people used called net-net. And for months, I used to sit there ignorant, thinking, what are they talking about? What is taken out of net-net that is left in net? This sort of supercharged version that they're subtracting something I'm not aware of. And I finally plucked up the courage to ask somebody what it was. It turns out there was no difference at all. They were the same thing. But everybody was just saying it twice for no particular reason. But they all had different conceptions of what they meant. And that happens in professional vocabularies all the time. So you've got to strip out what people mean when we talk about integration. It's very simple. We mean really that someone with an illness goes through many different NHS institutions, and it's a time-consuming mess for the patient. There's also, of course, very good evidence that integration can improve the quality of specialist services, such as cardiac, cancer, and stroke care. So the NHS is what we mean is it's a sort of episodic care service in an era when illness is no longer episodic. And that sounds an alarm bell to me, because you may then wonder why such an evidently good idea hasn't happened. The people have talked about it forever. Why are we still at conferences contemplating it, or monitoring its very unsteady progress? That's not just about politics. That's not just about the lack of will or lack of ability of the political machine to do something which is evidently good. It's that it is in itself intrinsically difficult to bring together the labyrinth of NHS structures. Now, existing bodies can merge, functions can be combined, the system can be simplified, or a team can be brought together by the relevant authority and contracts drafted with incentives for everybody to work together. But it always demands that somebody is in charge. And there's only three candidates, really, for the person of who's in charge. The hospital can extend its reach, the GP can take on a coordinating function, or some new agency or body can be invented to take on the task. Now, you don't need to know much about the fragmented history of the NHS to know that there is no natural body of leaders, and this is a site of endless conflict. The real story about the NHS is that fragmentation is written into it from its very origins. When in 1948 the hospitals were nationalised and the consultants became salaried staff in hospitals, that meant they were essentially deployed by the state. Primary care, meanwhile, of course, was established in GP services as private franchises. So the NHS is constituted a bit like America, deliberately so that no one's in control. It's very difficult to take control. It's very difficult to therefore integrate from the centre. And the task of integration is massive. It requires the coming together in any given health authority of about 1,000 people across 15 separate professional cultures to produce one single integrated mental health service. More than 4/5 of the services required to keep frail elderly people out of hospital are not, strictly speaking, even health services. And that fifth of required services which were within the fold of the NHS are provided by a huge array of different people. So we're asking a system to overcome the separation of budgets, the institutional chasm between primary and secondary care, and different streams of information and data. What prospect that this is ever going to happen? By the mere desire that it should happen, why do we ever think it's likely that it's going to? There's a long history that I won't bore you with of attempts to do so, of attempts to command into being the integration of a very fragmented system, the latest of which were the health and well-being boards. None of them have really ever made it. The very fact that we still talk about it demonstrates that. It's for all these reasons that the NHS Confederation, in a recent international survey of health systems, suggested that integration, which is mainly focused on bringing organisations together, certainly doesn't seem to produce better care. It doesn't even seem to produce any integration. The only possible way, I suggest, in which integration can feasibly develop is if it's wrapped around the individual. Let me give you an example, a relatively famous example, which comes from Torbay. It's the case of Mrs. Smith. Torbay Council had a terrible reputation for the quality of its services. It tried every method handed down from central government to improve them, but all to no avail. And it only really changed when Mrs. Smith came along. Now, Mrs. Smith was an 80-year-old resident of Torbay, and when the chief executive analysed the journey that Mrs. Smith had to take through the various institutions of their health and social care landscape, he was horrified. She had to undergo numerous different assessments. She repeated her story over and over again. It could take days for the relevant information to be passed from one body to the next. Mrs. Smith was quite well known in her local community, and her plight really resonated with the staff. She became a sort of metaphor for a new way of working, in which the professionals sought to fit around her rather than the other way around. Now, there's just one thing about Mrs. Smith I should tell you. She's fictional. She was just made up by Torbay officials to demonstrate how their world actually worked for real people. But she's horribly recognisable. Ever since Weber's brilliant work on bureaucracy, we know that one of the drawbacks of large systems is that people tend to get lost. But once Torbay kept Mrs. Smith in mind, they tore their bureaucracy up. Budgets were pooled to pay for new intermediate care services. Newly integrated care teams suddenly worked really well with GPs to help older people live independently. Some team members were charged expressly with bringing together the many things that Mrs. Smith need. With the focus on Mrs. Smith, the integration began to happen organically. And the revolution there has been a thorough success. Now, that strikes me as a template of the only way it can work, which is to revolve around a patient. I think there's a deeper lesson, which is that integration works even better if that patient is in charge of the process. And I think these changes are very difficult and troublesome for professionals. But when a patient takes up the option of a direct payment, for example, or a personal budget, they have the capacity to direct the care they need. The system is forced to integrate because me, the sovereign patient, makes it do so. Now, on condition if a plan is agreed with professionals, the patient is free to purchase what they need to alleviate their condition, even if that involves straying beyond the current boundaries. This, of course, implies a range of providers, a degree of competition, and we then get into the arguments about whether competition and integration are in terminal conflict. I used to play a lot of football with Andy Burnham, and we played for the demonised football team, the Labour Party football team. And he was a lazy centre forward who was parasitical on the hard work of all the rest of us and took all the glory and scored all the goals. And I used to say to Andy, who often will use the argument that integration and competition are enemies rather than allies, say, Andy, just think about our team. We were all cooperating, and our cooperation was all the more intense in our team because of the competition that we were facing. They weren't allies, they weren't enemies at all. The two things ran together. It was precisely the stimulus of the competition we were facing that rendered us capable of that cooperation. The two things worked naturally together. At which he said, yes, but that's football. But that marriage of cooperation and competition is a feature of all modern supply chains. It's simply not true anywhere to say that they're enemies. There are always rivals to supply goods, and then retailers of that goods have to compete to sell it. But think of the cooperation that has to take place before you even get to that point. Before the loaf of bread arrives on the shelf, an endless series of cooperative ventures have to take place. Adam Smith famously said that it's not out of the goodness of his heart that the baker will bake you bread. His incentive in the sale. But in order to carry out that sale, there has to be an integrated process that produces an edible loaf. And it's a deeply complex one, all of which is done because the incentives are pointing in the right direction to ensure that it happens. The incentives in this case are not financial, they are the personal needs of the patient. I remember at the time finding Danny Boyle's representation of the NHS in the Olympic opening ceremony cloying and sentimental, and saying so, and being the only person who thought the whole thing was awful. I feel better saying it now, actually, because I think a lot of lip service is paid to the idea of empowering patients in the NHS, but in truth, they're marginal. And if anyone was ever in any doubt about that, the Francis report leaves it entirely clear and obvious. To read the stories of incontinent patients left to die unattended in soiled bed linen is shaming. And many of those people testify that it wasn't the dirt that hurt them so much as the shame. To be humiliated in a ward in which nurses never called anyone by their name, to be visible to passers-by in a state of undress, was to be deprived of their dignity. And the most touching testimony of all to the inquiry was from the patients who complained that what most hurt them was that nobody ever thought to wash or brush their hair. The duty of care got lost in the rigid application of bureaucratic rules. Now, I don't for one second think that's a typical example. However, it shows what can happen in a system in which everyone's trying to do their best, and yet we get lost in the labyrinth of a bureaucracy. And the thing that was really important about Francis was that for years, people had been telling the hospital that it was a disgrace. The hospital management didn't count their stories as admissible evidence. It wasn't real knowledge. They were treated with arrogance and disdain, and the chief executive dismissed this high level of mortality as a coding error. Now, that's what can happen in a system in which the people are shut out. And the NHS needs to let the public in. It not only will avert appalling disasters like that, it will aid with some of the serious problems the National Health Service now faces, principally the management of chronic disease. The satisfaction of patients needs to be built into the judgment of hospitals and built into the pay of chief executives. Patients should have easy access to their own records, and it should be simple to find out where a hospital ranks, both the area and in the country. Boiled down to its essentials, the lesson I took from Francis was that the NHS staff are hoarding power and they have to be made to relinquish it. The NHS, to finish, is a system of command but very little control. The patients everywhere are sounding the trumpets on the city walls. Is anybody listening? This is a journey from the control of Mr. Hunt to the control of Mrs. Smith, but it has only just begun. Thank you very much.
Thank you. We've got some little bit of time for responses to that, and questions and reflections on what you've heard. While you're thinking, I'm going to ask you about... So we've heard about direct payments and personal budgets. I think they've really been sort of floating about as policy ideas for at least 15 years. the take-up is still really small, not just in this country, but in other countries that offer it. I mean, is this just still part of the professional conspiracy to hoard power, or is there something else going on there?
I think it's largely that. It's very hard local government is very tenaciously hang on to the power too. I mean, Alan Milburn's very interesting on this, a desperate attempt to try and drive it through. These changes take a very, very long time. I remember from being in government once, Tony Blair walking into the office, and we were talking about Job Centre Plus. And he said, but that was finished 10 years ago, but the first one was opening. And that's how long policy takes. So in a sense, you shouldn't be too gloomy about that, because these things take a very, very long time to really take hold. I just think it will. I think that over time, that policy in particular, and not just in the NHS, but across lots of things, will prove to be the way people wrest control of the service, which, after all, they are paying for.
Yes. I suppose one of the issues, of course, is you're saying our system's broken. We don't really understand how it works. It's horribly complex. So here's some money. Why don't you have a go? I think there's still a bit of an obligation on the system itself to become more transparent, less complex. I mean, community services are very. Does anyone understand how their local community services work? Even those of you who are managing them.
But Nigel, it's never quite true to say a system is broken, is it? Because it's too big for that, and there are too many parts of it, and there are too many good examples of excellent practice to be able to point to and say, well, actually, that's not broken at all. It's a bit like when David Cameron talks about broken Britain. I think, well, all of it? Everything's broken?
A slightly different point, which is handing the job of integrating the system to the patient is without first actually looking at. But I'm just going to pick you up on one other.
Depends which condition, though, doesn't it? I mean, because again, people always do this. If you make a suggestion, people say, "Oh, well, you can't do it for that." So, well, I don't suggest this is like the single answer to everything, but for certain conditions where and crucially where the patient has more information now than almost anybody else, and that's a new thing because they're living with it every day. That seems to me a viable candidate for my control rather than somebody else's.
Sure, absolutely.